Check out the full episode of the Bendy Bodies podcast on your favorite podcast app. Yeah, absolutely. If you don't address the root cause, then it's the problem is going to continue for sure. And that's where it drives me crazy that so often radiologists will put in their findings, they might comment that there's a Tarlov cyst. They won't say how big it is oftentimes, but they don't put it in the impression. So if somebody just looks at the impression, it's often not in there. Of course, that's just one of many things that can cause sexual problems, right, in this population of people. So, and there's even simple things, or I shouldn't say simple, but, one of the questions that I got was, well, what about tearing of the tissues down there? Because people have more fragile tissues if they have Ehlers-Danlos. So even something like that, that's a more maybe straightforward type of problem. Of course, it could be hormone related, but could be due to menopause, which is also obviously a big hormone shift in life. But are there simple things that can be done for that?
Well, yes. Estrogen testosterone creams can be done. They're compounded, so you need a provider for that. I was going to say something. Yeah, lichen sclerosis. We see, I don't know the association. I think there are, skin conditions are more common in individuals with EDS. And some of the skin conditions we see are lichen sclerosis, which makes the tissue less stretchy and more likely to have fissures. It's called fissures. They're typically at the 6 o'clock region of the posterior fourchette. And during sexuality, they tear and they really hurt.
And in terms of testosterone therapy and or estrogen therapy, there's different ways, right? There's the topical, and then you can also do like testosterone injections or different types of modes of administration. And I'm sure the contraindications are different depending on how it's being administered, but are you able to share some of those contraindications with us as well?
Sue, do you want to do it? You're on the, you were on the committee.
Yeah, well, so are you. I mean, the thing is that hormones are both systemic and local. So hormones that you apply to we're talking really to the vestibule, it's compounded testosterone and estradiol. It's such a low amount of testosterone and estradiol. I don't believe there are any contraindications to that. Inside your vagina, we prefer to use dihydroepiandrosterone, which is actually higher up in the cascade and becomes testosterone and breaks down to estradiol. And so it's what's cool about it is it's intracellular, so it doesn't actually leak into the bloodstream, so you don't get systemic hormones. It was developed by someone whose daughter unfortunately died in her 30s of breast cancer, but while she was still alive, he was trying to give her quality of life. He knew that she couldn't have certain fearful of certain hormones because of the breast cancer. And so he developed this whole concept of intracellular mechanism. He passed away a couple of years ago. He published more than 1,200 papers up in Canada.
Wow.
Brilliant man. So that's what we like to do. Although you can also put estradiol into your vagina if you're not able to get the DHEA. That's separate from having a systemic. So going into your whole body, testosterone can be delivered by injection, but it's really hard for a woman because it's such a small volume. We typically use the gel that's approved for a man, and we use approximately a tenth of a man's dose, somewhere between a 10th and a 14th, and it would be really adjusted based on where your levels are. We would follow up because we believe in what's the word I'm looking for? Monitor. We believe in monitored hormone therapy. So, at 6 weeks or at 3 months, we do blood tests and make sure they stay in the safe region. So what can testosterone do to you? I mean, testosterone can turn you into a man. That's what transgender women who want to become a man do. They get testosterone, but we're not giving you anywhere near that dose. People always say, well, I'm going to have a low voice. And I tell people I was a first soprano when I started on testosterone 23 years ago, and I am still a first soprano. Matter of fact, we used to only get up to a high G. I can get to a high A now.
Hey, Sue, who was your doctor who gave you the testosterone?
Oh, was that you?
Oh, yes.
You also get hair growth, but menopausal women get hair growth too. So, you might get a few hairs on your chin kind of thing. So, so you pull them out, you do electrolysis, whatever you want. I mean, to me, the positive of having testosterone, the benefits are far greater than any of the negative issues. I mean, most of the things that you hear about causing problems with testosterone is when you're getting a super physiologic level. You're getting too much testosterone into your system. I mean, when we are premenopausal, before you're on an oral contraceptive, we have X amount of testosterone in our bodies. And all we're trying to do is resupply some of that. Now, here, Linda, this may surprise you. Most people, you ask a gynecologist how much estradiol you have in your body and how much testosterone. They'll say, oh, you have far more estradiol. Far more estradiol. So is that true? Do you have more estradiol or more testosterone in a premenopausal woman?
I'm guessing that that's not true because otherwise I don't think you'd ask the question.
So they look at graphs and they say, okay, you have this much estradiol and only this much testosterone, but they don't look at the fact that the actual
units
is different. Women have 5 times the amount of testosterone in their body than estradiol. So to replace estradiol in menopausal women and say, well, you don't need testosterone because there's so little is bogus. I mean, I just had a DEXA scan. I'm sorry, we're going off target here a little, but I just had my DEXA a couple of weeks ago, and my percentage, I'm a 75-year-old woman. I'm not embarrassed to say my age, and my DEXA should really show, losing on my hips and my spine. I gained 4.6% on my hips. I do not take Fosamax or any of the other things. I do not eat. I eat very little cheese. I don't drink milk, so I'm not getting calcium. It's because I take testosterone and I exercise, and the testosterone gives me the muscle strength and the energy to exercise, and and exercise and testosterone both help maintain my bone mass, and in this case, get it better. So, if we're going to talk about side effects, there are positive side effects and negative side effects, and you couldn't pay me to get off the testosterone because it keeps me healthy, as do the other hormones that I'm on. And I'm sorry, I went far afield, so I apologize.
No, that's okay. And actually, I did want to follow up with 2 questions. One is, you were talking about monitored hormone replacement therapy, and
so
I know,
important.
Yeah, so important. I totally agree. There's a lot of people that are doing things like pellets. Now, once you put that in, right, you can't control the dose until you do the next pellet. So, what are your thoughts about that?
We don't do pellets. I think it's, I don't know how to say this, for people who do pellets, I think they have other ulterior motives in place. But I think the issue is you should do something that you could stop at any time if there's a reason, and you can't do that with pellets. So I think it's just unfair to the person. Now, having said that, there are a group of people who love pellets who think it's a fabulous treatment, but it's just a little bit unsafe. The ideal way is to take it daily, like everybody else takes their pills daily. You can take this daily, and you can monitor the dose with blood levels. There's a second monitoring system. We do a thing called vulvoscopy, which is basically an intense camera placed between the legs and staring at the vulva. And that means the patient gets to see what we're seeing, which is an amazing experience because people have never seen the inside to their vagina. And whatever.
Or the outside.
Or even the outside.
Most women don't look down to see what they look like. They don't even know their body parts. They tell you it hurts down there.
When you do vulvoscopy prospectively in people who start off with menopause and then go into issues like now 1 year on treatment and 2 years on treatment, you see the tissues turn pink and healthy and lubricated. It's such a pleasant thing to watch the longitudinal improvement. So the monitoring is visual and hormonal blood test based.
But for people who want to learn more about testosterone in women, ISSWSH did develop a process of care of how to prescribe, basically how to use testosterone in women. One of the things that the FDA says, if you put testosterone into cream, it will layer. It's fine for the topical testosterone and estradiol we put on the vestibule because that's such a small amount. But if you're going to get a tube from a compound pharmacy, like a big tube like this, it's the amount of testosterone on the top is different than the amount on the bottom. And so that's why the FDA says don't do that. That's why we choose to use an FDA-approved product. And the pellets you were just talking about, unless you're using the one FDA-approved product for men, none of those are FDA approved, which means that they don't necessarily, the guidelines they have to follow are far different than FDA approved products. So take a look at the ISSWSH paper on testosterone. It'll tell you all the pros and cons, all the rationale, the physiology, the safety issues. It's all there, to be seen, to be read.
Okay.
And another thing, go ISSWSH. Everybody should read, learn, know about ISSWSH and become members. Linda, you should have to become a member there. Oh my
Well,
God.
I'm doing a presentation at the Ishwish conference next month.
Oh my God.
Yeah.
We'll hug you big time.
I can't wait to see you. I was invited to give a presentation, so I'll be talking about
so cool
sex problems in this population with a pelvic floor physical therapist, a friend of mine. So we're together doing a presentation.
Pop quiz, one more pop quiz. When did Ishwish start?
Oh my gosh.
What is this year? This is our 25th anniversary.
Oh, yes.
The year 2000 it started.
And I want to make sure that we talk about libido because these problems can cause so much difficulty with sex, of course, which is so important for relationships. And as we talked about, it can be also problems with sitting and wearing tighter clothing or, other aspects of their life. But let's talk about libido and how you have seen these conditions impact people and their libido and what can be done about that.
Okay, before we start, I just want to say, Linda has announced that she has a sexual health issue, the Tarlov cyst, which led to her issues. And as Sue's husband, I know that she has had this libido problem. And in the medicine, we call it HSDD, hypoactive sexual desire disorder. And I think it's very cool that both of you are we're talking to the public about these things, but you both have at least something. So I think it's very genuine what's going to happen here.
So HSDD, it's very interesting because a lot of women don't recognize that they've lost their libido, that their desire is down. They're busy leading their lives and they don't let it bother them. They just go on. And for some people, they're having duty sex because they love their partner. And once they're having duty sex, during sex, they may have responsive desire. And so things feel good. But a lot of times it'll be, okay, you had sex yesterday. How was it? Oh, it was good. Well, you want to have sex tomorrow? Who cares? There are a lot of different responses. Lillian Arlecue and I co-authored a book many years ago, When Sex Isn't Good. And I'm not giving a plug to the book. It's not relevant, except that we went out and we interviewed women with different sexual problems. And I think one of the most telling interviews with the women with low desire. One woman said, I dressed beige. I acted like a wallflower. She says, until I was treated. When I was treated, I started wearing fun, funky clothes again. I started driving my stick shift car. I started doing things again. And I always remembered that. For me personally, I literally wasn't having sex very often. And I thought, and it wasn't all that great. And I thought, oh, my husband is ED. How am I going to tell this world famous ED doctor he is ED? But I mean, he didn't. There's nothing wrong with him. And literally, he came home from the office with the Female Sexual Function Index, which was a brand new questionnaire at the time, developed in order to figure out if a medication was effectively treating people in clinical trial conditions. And I took it and he goes, holy you've got HSDD. Like, it didn't dawn on me, as engrossed as I was in the field, it didn't dawn on me that it was me because we really didn't know a lot about it. Mm-hmm. And for me personally, at the time, the only really good treatment was testosterone. And I was on testosterone for years. And the way I put it is, when I was 25 and sex was great, now I was in my 50s, and instead of sex being a 10 out of 10, it was more like a 2 or 3 out of 10. But that was fine because that was better than a 0 out of 10. Mm-hmm. And sex, sometimes I was interested and sometimes it was duty sex, and then I became interested. And I'm telling my story only because I know a lot of women can relate to this. And then one day the testosterone stopped helping me, and I turned to my husband and I said, okay, now you have to fix me. I know what it's like to have my libido back and it's gone again. I recognize it. At the beginning, I didn't recognize it, which is what happens with most people. I knew, I said, fix me. Well, ironically, it was just about the time that flibanserin, the trade name is Addy, was approved. So I had to wait about 3 months for it to be available. And then that October, I got my first pill. Now, today we have a second treatment as well called bremelanotide, or trade name Vyleesi. So we have 2 options out there for women in addition to testosterone. So we have options out there. But for me, what I found most remarkable was that I hadn't realized how much was missing in our relationship until it was back, because these drugs are central mechanism drugs. That means they work in the brain. I tell people they reboot your brain. Somebody said, well, am I going to become a nymphomaniac? I go, well, were you a nymphomaniac when you were 18 and healthy? No. Well, it's going to bring you back. So now my sex is, 8, 9, and 10 out of 10 much of the time. I'm a normal person. There was a day I'm exhausted and sex sucks. Excuse my language.
check out the full Bendy Bodies podcast episode on your favorite podcast app.